I am doing a report on a patient with the initials CP. Patient is a 56-year-old Caucasian female who is married and lives with her husband. She reports being retired from the airlines since 2005. Her primary source of medical care is her primary care office. Her vitals are as follows: blood pressure 170/90, temp 98.7 degrees Fahrenheit, respiration rate 13 breaths per minute, and heart rate 74 beats per minute. Her reason for seeking care today is for her monthly IVIG infusions for her diagnosis of hypogammaglobulinemia. Patient states that she was diagnosed with hypogammaglobulinemia, an immunodeficiency of low IgAs, IgGs, and IgMs in the blood immune system on August 30th, 1991. Patient reports she has been doing monthly infusions since December 1st, 2001, and had a chest port placement in October of 2006. Patient states that she receives her infusions because of her low immune system. They tend to help with her energy for 2 weeks out of the month. Patient came in today feeling fatigued because she is due for her infusions. To help with her fatigue, she has been resting in bed and avoiding strenuous activity, which usually makes it worse. She states that she is very cautious of going into public when she is feeling fatigued because she knows it is a sign that her immune system is low, and if she gets sick, it would impact her daily activities and increase her caregiver burden. In the past, the patient has reached out to her friends and family to help support her through the diagnosis. The patient also reports a need for transportation to the hospital for her monthly infusions. Patient has yearly MRIs to monitor 3 conditions. The first is a large venous angioma in the right cerebral hemisphere of the brain. The second is a 1.5 hemangioma in the right hepatic lobe of the liver. And the third is in her spine, lumbar, thoracic, and cervical regions, monitoring 18 lesions, tumors, and cysts. She is diagnosed with orthostatic hypertension. Patient reports a strawberry hemangioma. She reports being born with a large red mass that covered the right side of her nose. By the age of 12, it started to slowly disappear, and by the age of 15, it was almost gone. Patient reports being diagnosed with von Willebrand's type 1 on March 17, 1995. Prior to, during, and after any surgeries or procedures, the patient reports that she receives infusions of DDAVP followed by Amicar. On April 10, 1975, at the age of 15, the patient reported that she received a biopsy of a tumor in her right maxilla region. The pathology report came back as a very aggressive fibromatosis. From there, the patient has received 36 surgeries to date on her right maxillary region. Patient reports removal of right ovary on May 22, 1985, and a complete hysterectomy on October 17, 1988. Patient reports on January 14, 2010, that she slipped off her porch and fractured her left ankle. And on April 4, 2015, she fell walking and broke her big toe on her right foot. Patient also reports a severed left thumb tendon from using a table saw. She had surgery to repair her left tendon. Patient reports being admitted to the hospital for a TIA on August 31st, 2014. Patient also reports a history of type 2 diabetes, diagnosed in 2017. Patient reports no history of eye surgeries. Patient reports being up to date on all immunizations and has no drug allergies. Patient is on numerous medications to treat her hypertension and pain. All of her medications are taken orally via tablet form. She takes medications at 7 a.m., 11 a.m., 3 p.m., 7 p.m., and 11 p.m. She can take 5 milligrams of midodrine as needed if her BP is lower than 100, and 10 milligrams of Flexeril as needed for her back pain. Patient reports smoking 1 pack of cigarettes a day and that her alcohol consumption has been more than it ever has been, reporting having it a couple times a month. She takes no illicit drugs and reports having 4 16-ounce glasses of water a day, sometimes more. She does housework on a daily basis but no formal exercise. She reports sleeping well, going to bed at 10 p.m. and waking up at 7 a.m. She typically does not eat breakfast and only eats 1 meal a day. If she snacks, she has fruit. She has 1 cup of coffee in the morning and 1 pop throughout the day, and reports using a seatbelt in the car. She does not have smoke alarms or carbon monoxide detectors in her house. Patient is a highly motivated, easygoing, and independent woman. She reports having a wonderful support system at home. She identifies that her stressors include fatigue and worry of getting sick and not being able to receive her monthly infusions. Patient does not participate in any organized religion, but reports that she believes in God and has faith. She fully believes in the power of prayer. The patient has a sufficient income to cover the cost of food, housing, and medical care and is rarely alone. Patient reports a family history of hypertension. Grandmother and mother both were diagnosed with hypertension. Because the patient came in with the chief medical diagnosis of hypogammaglobulinemia, I first assessed the respiratory system. Patients with this diagnosis do not have an immune system, therefore they are more prone to infections. That being said, I assessed the respiratory system to ensure that the patient did not have any infections, making it difficult for her to breathe. Patient denies cough or sputum, shortness of breath, dyspnea, and chest pain with breathing. Patient reports a history of multiple sinus infections. Denies environmental exposures to toxins and environmental allergies. Denied history of TB or asthma. TB test done 5 years ago was negative. Immunizations are up to date. Patient reports smoking since the age of 15, 1 pack a day. Patient states that her physical activity includes doing household chores and occasional workout videos. Upon examination, the thorax was even in color and the AP transverse diameter was 2:1. Furthermore, there was no new injuries or deformities other than the patient's port. Spine is straight and the symmetry was equal on both sides. The patient's breathing pattern is normal with a normal rate. Patient does not report any problems breathing. Patient does not have any cyanosis or clubbing of the fingers. Upon palpitation, the trachea was midline and the sternum was straight. There were no bumps, masses, crepitus, or tenderness. Tactile fremitus was equal and symmetric, and expansion was symmetrical. Upon auscultation, lung sounds were clear and there were only vesicular sounds as to be expected. The first article that I reviewed was titled Hypogammaglobulinemia, a diagnosis that must not be overlooked. According to Pimentra, the author, the respiratory system must be assessed for patients with hypogammaglobulinemia. This is because chronic lung disease is a common cause of recurrent hospitalizations, worse morbidity, and mortality in patients with this diagnosis. Furthermore, the author states that it is important to review the system because about 30 to 60% of patients with hypogammaglobulinemia develop chronic lung disease due to inflammation of the airways. Upon examination, wheezing, rhonchi, and crackles may be present. In addition, clubbing and cyanosis must be assessed. The next system that I assessed related to the patient's chief diagnosis was the heat system. Common symptoms of patients with hypogammaglobulinemia include a sore throat, ear pain, sinus pain, and congestion. Therefore, it is necessary to review the patient's head, ears, eyes, nose, and throat in order to ensure that these symptoms are not interfering with the activities of daily living. Patient reports headaches at least 2 times a week. Reports unbearable pain if headache is present upon waking. Patient denies dizziness, vertigo, and fainting. Denies pain in head, ears, eyes, nose, and throat other than when headache is present. Reports vision changes. Appointment with an ophthalmologist is scheduled. Patient reports hearing is intact and no bleeding or discharge from ears, eyes, nose, or throat. Last dental exam was in September 2021. Denies voice hoarseness and frequent colds and strep throat. Patient does not have issues swallowing and does not report neck pain or tenderness. Patient has 20/20 vision with glasses on. Upon examination, the skull is normal cephalic. Pupils are equal, round, reactive to light and accommodation. Peripheral vision is intact and no deviation in the eyes. Furthermore, tympanic membrane is clean and shiny. Hearing is grossly intact. Nose is midline to the face. Nostrils are pink and moist and there is no septal deviation. Gums and tongues are pink and moist. Patient has missing teeth, which is to be expected from the medical history, and the oropharynx is pink and moist. Tonsils are 1+ and lips are even, and there is a full range of motion of the neck. Upon palpation, there are no bumps on the skull and there is no pain with the lacrimal apparatus. No pain upon palpation of ears or sinuses. In the lymph nodes are not present. Cervical spine is intact, and the patient has a negative Romberg test. The second article that I reviewed was titled Common Variable Immunodeficiency. According to the authors, during the physical examination, the heat system should be reviewed thoroughly. Specifically, upon initial assessment, careful evaluation of the cervical, axillary, and inguinal lymph nodes should be performed. This is because adopathy, swelling of the glands, is very common and can be quite profound. Report of these systems came back normal as the patient is on medication to control their hypogammaglobulinemia and is in today to receive her infusions. And that completes my assessment for today.